So I'm delighted to welcome you all for our midwinter talks. And today it's going to be in the 50s, but don't get used to it. So our first speaker today is Dr. Evan Morris. He's Associate Professor of Diagnostic Radiology and Biomedical Engineering, Co-Director of Imaging at the Yale Pet Center. And this is a good time for me to remind everyone that Yale has terrific research imaging resources, both for humans and for smaller animals, and both in the radiologically based methods and for MRI. So if you'd like to learn more about these resources, you can look for the centers or just ask me. In any case, Evan's going to be talking about work that's close to my heart, which is how to design a PET experiment to image the EGF receptor.
This is not my talk. Okay, well, thank you for inviting me. Can you hear me? Okay, good. So, without further ado, that's me over on the right. I'm the official greeter at the Pet Center on Howard Ave. You can see me out there anytime you need to buy toilet paper or shoe polish. And this is my buddy Joe Contessa. He came to us a few years ago and he said, "Evan, I have a model." And I said, "Fabulous. I'm all about models." Of course, Joe was thinking this, which is probably what all of you in the audience are thinking. And I was thinking this. But in any case, okay, so obviously mine is a kinetic model, and his is an animal model, and I'm not expressing any preference. I'm agnostic, just we have to know who's who. But so we were undeterred. He says, okay, I've got a receptor. And I said, "That's cool. I love receptors." He says, "It's better than that. I've got a receptor and I've got a ligand for the receptor." I said, "I'm all about ligands and receptors." Of course, Joe was thinking this, and I was thinking that, ligand bound to receptor. At this point, Joe and I started to have serious misgivings about this relationship. In any case, despite our widely differing worldviews, we decided to mush on. Okay, so had I known you all better, this is the talk title I would have submitted. What could PET do for Joe? And what did he need to understand first about it? And that's what I'm going to try to talk about. So the first thing you need in PET is a tracer. And there's generally three sources for tracers. Either the drug of interest, in our case erlotinib, can become the tracer if you have a sufficiently talented radiochemist, and it might turn into 11C erlotinib. Or you can use a tracer, even if you're interested in the action of erlotinib, you can use another drug which you think binds to the same site, like 11C gefitinib, or you can label an endogenous ligand for the receptor site. In this case, gefitinib turns out to have too much background activity, and labeled EGF would almost certainly bind extracellularly, and that's not where we think we're looking. It's not a competitor, I don't believe, for erlotinib. So we were stuck with erlotinib, and it just so happens that people had already made it, so that was great. Okay? All right. Now, I had those pictures of the kinetic model, and you thought that was just my opening joke, but really that's what I'm going to talk about a little bit. Why kinetic modeling? So there's our slice, our imaging slice, and if we dig down deeper, there's my region of interest, and in my simple way of thinking about things, that's what's inside my region of interest. There's a blood vessel, there's an alveolus, there's a cell expressing epidermal growth factor receptor, and there are those little yellow diamonds, which are the labeled drug, which is our tracer, carbon-11 erlotinib. Okay? And the tracer can take on different states. It's bound, it's not bound, and sometimes it's stuck non-specifically to a membrane or some other piece of something because no tracer is perfect. Now, I take that general information and I convert it into this. There are different, distinct, but connected pools of tracer. They're different states, and they have this connectedness that I imagine. I'm not positive this is true, but this is basically always the scenario. Okay? And so the free box or pool represents the tracer. The B, the bound box, represents tracer bound specifically to the target of interest. N is non-specifically bound. It's that stuck problem. And the total number of receptors is represented in the model as well. Okay, and for those of you who actually do this type of modeling, you know that once you draw that picture, it just proceeds naturally to a series of differential equations. That's not a big deal. The picture is the thing, okay? The connectedness is the thing. The equations are just how we actually turn that that connectedness into a prediction of what the data will look like, okay? And one point I want to make, which I'll come back to, is that all models need an input function to drive them. In this case, the input function, P of t, is the delivery of erlotinib, the tracer, to the tissue via the plasma, okay? But I'll come back to that. But that's an important part of actually being able to solve this model and predict what the data will look like. Now, of course, those are all necessary states. The tracer can be bound, it can be free, it can be in the plasma, but honestly, none of you or I really care about all those states equally, right? Its therapeutic action of erlotinib is not in the blood. We know that, right? But I need to put it in there to complete the model, okay? But the problem is, how do I tell the difference? Because I'm here to tell you that PET scanners are dumb. They're not smart like phones. They're just dumb. They can't tell the difference between tracer that's bound or tracer that's free if they're all giving off radioactivity, right? The only way to tell the difference between all of those different tracer states is to look at them over time. They have different temporal trajectories. The plasma-borne radioactivity is only there for a short time. The bound radioactivity persists for a long time. The PET scanner sees only that sum of the signals, the black curve, because again, it's stupid. And it's the kinetic model that teases apart the different components of the signal over time. Okay, there it is. And there's our plasma input function again. If the model is properly constructed and you measure the delivery of tracer to the tissue of interest, that's the P of t, then solve the model, it will predict the data beautifully. Those are actual fits of the model to the data in different regions, which I'm going to describe in a moment, over time. If you don't measure the plasma input function, or have some other way of knowing what the delivery of tracer is via the blood to the tissue of interest, then the model will give you that. That's bad. Doesn't look anything like the data. Okay. Now you have to know also when you design an experiment, what's your endpoint? The endpoint in most of these studies, when we're dealing with a labeled ligand and a receptor or a transporter or an enzyme, is binding potential. And binding potential is a parameter of the model I showed you, and it represents, it's a surrogate for the number of unoccupied sites, number of epidermal growth factor receptor sites where the tracer would bind. practically speaking, you measure it in terms of something that you measure from the tracer, because that's what's giving you the signal, and it turns out to be the steady state ratio of bound tracer to free tracer. Now, you may never get to steady state. Steady state might happen way, way off in the future after I retire. But we can estimate steady state, and that's a parameter of the model, and it represents this density or number of unoccupied sites that we're interested in. How many binding sites are there in the tissue for for erlotinib? And underneath the hood, you have to keep in mind something I'll come back to. Remember, it's a surrogate. The unoccupied sites are only proportional to what we're estimating for mathematical identifiability reasons. And you have to keep in mind that the proportionality of what you measure versus what you're interested in is the affinity of the tracer for the binding site. I'll come back to that too. Okay, now, I'm sorry, but some of that was a lie. But I didn't put those cones up on the bridge, and I didn't make the lie, my slides lied to you. So what was my lie? Well, this is the picture I showed you a minute ago, and all of those erlotinib molecules, the diamonds, are yellow to imply that they're radioactive. But even if you have the most fabulous radiochemist in the whole world, and they might actually be in the basement of 801 Howard Street where we keep them chained to their hoods, they can't make every molecule of erlotinib radioactive. So the picture really looks more like this. There's lots of cold carrier. It's unlabeled erlotinib also, right? And that in and of itself is not a problem, but we sort of have to focus in on what consequences that has at the receptor site, which is in the circle, if cold carrier progresses to excess cold carrier, and I mean excess relative to the number of receptor sites, and in that case, see what happens? It looks just like that. You see these little diamonds floating out of the PET scanner. There's blocking, right? Did everybody catch that? I get to show you that one again. Maybe not. Oh yeah, come on. Let's watch it one more time. And it's about to happen, and there's displacement. I love that slide. Okay, so in this case, notice what's wrong. What's wrong is that the dumb PET scanner is going to measure all the activity coming from the diamonds, right? But none of those diamonds, none of the carbon-11 erlotinib is actually bound to the tracer, the binding site, right? The green receptors. It's just in the blood, it's floating free, it's stuck to something it shouldn't be stuck to. So the image, which will still exist, won't have any information about binding or the target in it if we put ourselves in that situation of excess cold carrier. Okay, there it is. That's excess erlotinib. Okay, so I think this is an important point to say what I just said another way. Excess cold carrier leads to total blockage of specific binding in contradistinction to non-specific or stuck, and that would result in a binding potential of 0, but if you're looking at an image of uptake or using a measure called SUV, which you're all familiar with, which is sometimes the best you can do, you still get a signal. The arrows don't lie. There's still activity in the field of view, but none of it represents binding to the target. Okay, so what happens is, in the case of total blockade of the receptor sites by cold carrier, the temporal trajectory of your data looks different. It looks more like this. There is no binding signal, and the total that the PET scanner sees is the sum of only what's plasma bound and what's free, and there's no information about binding there. But this is still important for a reason I'm going to get to in a moment. Okay, so here we are at that moment. what do we want to do is 2 steps by which we demonstrate unequivocally that there is specific binding of your tracer to the target site of interest. First, we have to show that this thing binding potential, which represents unoccupied sites, is not 0. And then we have to show that in the case of excess cold carrier, it goes to 0. You can block it or you can displace the signal. Okay? Now, here's what did we actually do, Joe and I and our friends. Well, we started back with Joe's model, and everybody in this audience, I'm sure, is familiar with these tumor types. Joe, I shouldn't take any credit, grafted different tumor types, either wild type or those expressing EGFR, onto nude mice. And you're familiar with these tumor types. HCC827 and PC9 express kinase domain mutants. And U87 is a wild type, and U87 delta has an extracellular domain mutation. Okay. They're both called, a lot of them are called activated, which confused me for a long time, but they have different types of mutations. And then we're asking this question, which of these tumor types does erlotinib bind specifically? Which ones does it bind to displaceably? Okay, so that's what it looks like when we take our nude mice and place them on a pallet and immobilize them. They're still alive, and we slide them into this scanner, the Focus 220, and they look red over on the side because they're under a heat lamp to keep them warm. And we inject them with a little bit of carbon-11 radioactivity via retroorbital injection in this case. We image them on this Siemens Focus animal scanner, which has a resolution of 1.4 millimeters. We image them for 2 hours. We reconstruct the dynamic images. And remember, everything is about dynamic measurements because it's only the temporal trajectories that help us hone in on the signal we care about. We draw regions of interest over the tumors and some healthy tissue. We fit those kinetic models I was making a big to-do about to the data, and we estimate binding potential, which we use as our surrogate of unoccupied sites. And that's what the data look like. On the left is a transmission scan, which is used for localization. It's part of the whole process. Then there's an early PET scan and a late PET scan. I get all of them over time. I'm just showing you a few for illustration. And then the blue sketching on the right shows you where we drew the regions on these 2 tumors that had been grafted onto the flanks of this mouse. And you say to yourself, well, what's up with this early and late stuff? Well, early means that you take that image represents mostly free tracer. You can see it there. Early is on the left, and so it tells us something about flow. And on the right, the signal is primarily binding, and it tells us more about where the stuff is binding to the target. Okay, in any case, that's what the data look like. There's a whole lot of what we think is non-specific accumulation in the gut, but what we really care about is those tumors on the flanks at the bottom. And here's our data over time in 2 tumors, HCC and PC9, which have the kinase domain mutants, and 1 wild type SW620, which effectively doesn't express EGFR. And the model works flawlessly. It fits the dynamic data, and from that we get an estimate of binding potential, which I'm going to withhold from you for another few slides. On the other hand, you see something clearly different here in the temporal nature of the data. U87, the wild type, and U87 delta, the extracellular domain mutation, look different. The model still describes the data, but you'll see in a moment that the result is different. Okay. Now, we also did step 2, which, remember, requires excess cold carrier. All the exact same steps, exact same slide, exact same everything, except that just before we inject, we add an excess of the drug, which is the cold carrier, just plain old unlabeled erlotinib, in sufficient quantities that we know we're going to block up all the sites. Okay? Everything else is the same, and then the data look, whoa, drastically different in the case of the kinase domain mutations, right? None of that big accumulation. The model still fits the data, but there's clearly something different, which I'll show you momentarily. And not surprisingly, for the UH7 and the UH7 delta, there isn't that much change in the data. The model still fits it, but as the next slide will reveal, it's sort of an uninteresting result. Okay, so taken all together, this is our finding. SW620 is not different with and without cold carrier because there are no binding sites to block up. HCC, A27, and PC9, which have the kinase domain mutation, those are the ones whose signal is considerably due to bound tracer to the target site. And so they're different from zero, and they're also quite different when you add excess cold carrier. You eliminate that specific binding signal, so that's a confirmation of sorts. And finally, not surprisingly on the right, UH7 and UH7 delta, there is no difference whether you have that cold carrier or not, because the tracer is not binding specifically or displaceably to a target. And so, to conclude, this is what we think we found so far. We believe that this has definitively demonstrated that erlotinib, because of course the tracer and the drug act exactly the same. The presence of the radioactive nuclide has no effect. Erlotinib binds specifically to the EGFR with kinase domain and not extracellular mutations, and we think that this is the first demonstration of this because we did the high cold carrier experiment. And if you think about PET as a way to do multiple biopsies at the same time non-invasively, then we think our second conclusion is that carbon-11 labeled erlotinib and PET could be a means of treatment planning in the case where we're trying to differentiate TKI sensitive from TKI resistant EGFR mutants. Okay? And finally, this is looking ahead and to try to bring back a few of the points I made as we hope, with the help of Sarah Goldberg, to go into patients now. Our goal would be to determine the appropriateness of erlotinib as a treatment planning device, the lack of arterial lines. Remember, the need for a plasma input function to know how much tracer is delivered to the tissue is a problem, but luckily it's a surmountable problem. There are other models and other assumptions we could make, which we can talk about another time. Here's another concern. I don't think you can image people who are being treated, because think about the cold carrier case, right? All their sites are blocked up. We're not going to get any signal that relates to the presence of the target we care about. So you have to take them off treatment. So that becomes a tricky logistical and ethical issue, which we've already started to talk about. And finally, if anything that you do as treatment changes the affinity of the tracer for the binding site, recall from an earlier slide, you're going to change this proportionality constant between binding potential, our surrogate for unoccupied sites, and the true number. And that may or may not be an issue, but you have to keep that in the back of your mind. Okay, so that's what I've got. These are all the people, first and foremost, Joe Contessa, who envisioned and helped and drove the whole study. Our first author on our paper, Ryan Petrulli, who's my student, Jennifer Sullivan, who was a previous student who started the ball rolling, Ming Cheng is one of those fabulous chemists who makes lots of yellow diamonds. Dan and Jonathan were in Joe's lab. Henry Wong is the head of chemistry at PET, so you come to him if you've got some other molecule you want labeled. And Sarah is our newest team member who's going to turn this into a fabulous clinical project. And of course, we started with Joe's YCCI Scholar Award. That's it. I'm happy to take questions if there's time.
Are there questions?
So So do you envision this could be a predictive marker for who would respond to the drug? Is that kind of what you're leaning toward?
Yes, yeah. So as I understand it, we may encounter people who come in, first of all, they have to bind the tracer to have any hope of being susceptible to the drug. But even then down the road, once they become resistant, because you can't take biopsies everywhere, do they still have any tumors worth treating with erlotinib? We could assess that also potentially with this tracer. The simple answer was yes.
So I'm wondering if the receptor was activated by EGF, for example, would you expect the erlotinib to bind?
Ha. Okay, so help me out a little bit. It would be
Would activate.
if it's activated just by the presence of your endogenous growth factor. In the absence of that mutation, then we think it would not bind. But do these two things happen separately? That you think EGF activates, meaning dimerizes, I guess?
The reason I'm asking is there are many cases where these receptors are activated endogenously by autocrine circuits, for example. So if you could image those situations too, it would be interesting.
Right. So as I understand it, the U87 tumor is a model for that. It's constitutively dimerized, but in the absence of the kinase domain mutation, it doesn't have any specific binding.
I was wondering if you could comment on the amount of actual material that you need to give to get a good signal, and how that would, in thinking about translating this to a human trial, how would that really translate in terms of the amount of material that you would really need to discern a really good signal?
Okay, so that's a good question for a couple of reasons. The amount that we need to make a good image is always minuscule and has no drug effect. I mean, we call them microdoses. The PET scanner, although I told you it's dumb, which is true, is highly sensitive. So we only need, picomolar quantities, nanomolar quantities, nothing that has a drug effect. In fact, that's an important distinction that I glossed over, which is anytime I call something a tracer, inherent in that statement is I'm not giving a drug effect, a drug amount. It's only when I start giving excess cold carrier that I start to have a drug effect. So it shouldn't affect treatment, okay? And it doesn't do any treatment, just giving the tracer and imaging. Yeah, I mean,
Can you repeat the question?
yeah. So the question is, if we know what the in vitro affinity of the ligand is for the receptor, can we estimate can we estimate the in vivo affinity? And the answer is yes, potentially we could estimate the in vivo affinity, but what you have to do, just like with a test tube experiment, is you have to modulate the concentrations. So you'd have to be able to modulate the amount of cold that you give. But you can do, sure, we estimate in vivo affinities of tracers, if that was, important.
Could you tell us something about the choice of label? You used carbon-11, but there's like fluorine, there's yttrium, there's even zirconium, I guess. A lot of drug companies are interested in zirconium today.
Yeah, so this is a very good question also. And there is, as I sort of maybe glossed over, There is an F-18 version of gefitinib I'm aware of. So mostly we play with carbon-11, which has a half-life of 20 minutes, and F-18, which has a half-life, radioactive half-life of 2 hours. And we try to match the kinetics of the tracer with the persistence, you might say, of the radionuclide. There are some reasons why we might prefer F-18 tracers. It makes research less stressful. It certainly makes action in the clinic less stressful. It would be totally impractical, I think, to do this on a patient with a carbon-11 tracer. On the other hand, carbon-11 gives us certain other options. We can do multiple studies on the same day because there's no residual radioactivity from early in the morning. And I should have said that our tracer experiments on those mice and then our excess cold carrier experiments were on the same day. We couldn't have done that with an F-18 labeled version of erlotinib.
Okay, well, thanks very much. We have time maybe for one more really quick question.
Would you come on the resolution? So you have 1.4 millimeter. That's for small animal, right? If for a larger object, what is the inference to your conclusion?
Right. So I should have said also, this is a question about resolution, the tumors were quite large. They were 1 centimeter, so there's no problem finding the tumors. In this scanner, which is for small animals, or for animals, I should say, as you point out, the resolution is about 1.4 millimeters. We have a brain scanner, which isn't going to help with lung tumors, which has 2 millimeter resolution, and we have a PET-CT, which is on the order of 3 millimeter resolution. But that's, of course, and I'm getting off the stage, tells us something about our ability to resolve nearby things. If you have something smaller than 3 millimeters, it doesn't mean you can't find it. You just may not be entirely quantitative, but you can still find a tumor that's smaller than that. Okay.
Okay, thank you very much, Dr. Morris.